This patient has pseudoexfoliation, a poorly dilating pupil, and so we'll have to deal with that as we do this cataract implant procedure. Here we're using the toric axis marker to mark the desired axis for a planned toric IOL, and there's our side port incision, and now a 2.4 millimeter keratome primary incision. Little intraocular lidocaine. And now we'll put in some viscoat. Sometimes the pupil expands, didn't. This is a Beeler 2-prong pupil dilator. So we'll hook the subincisional iris and then use the 2 prongs to stretch the pupil. And more viscoat to expand the stretched pupil. Now that's a bent tip 25 gauge needle to incise. The anterior capsule has got the little incision in it now. We're going to just grab the capsule and do our rhexis, basically following the curvature. And we can see some stria there in that nasal area. And there also. So our zonule may be a bit suspect here. Sometimes we'll insert capsule retractors. We'll see what we think. There's hydrodissection. And now viscodissection using viscoat. And we'll do this viscodissection in this eye for 360 degrees because of the pseudoexfoliation and very possible zonular laxity here. Alright, so there's the curved big ball chopper and the phaco tip. So we'll aspirate some of these bubbles and cortex first. So I'm going to stabilize this nucleus as I sculpt into it. You can see the view is a little suboptimal. Why is that? Because there's some cortex here, quadrant removal. So I just came up and aspirated back to sculpt. So I can get a better view, and I need a good one here to see the depths of the nucleus as I sculpt it. Because I want to divide this lens without having to hopefully separate instruments very widely. Meaning I want to be nice to the zonule. So let's see if we have any nuclear segments that we can remove. There's a little one. That was the first one. And there's one more there, quadrant removal. Okay, so now we'll do bimanual rotation. Sculpt. So with some of the nucleus removed, we have a decompressed capsular sac, quadrant removal. That's kind of a heminucleus that I'm just kind of taking a segment off it. And wet the cornea, please. And I'll lift that segment up. Good. So we haven't done a lot of nuclear rotation, some. So we have an obvious zonule failure here. So here in slow motion, we get to review what just happened. And you can see it looks like vitreous strands coming right over the top of the capsule. Here I put the chopper out into the equator to hold it back, and it held it back in one area, but to the right of it, there it came again. So time to come out and go to plan B, namely to fill the lens capsule with OVD and put in capsule retractors. So here goes the OVD down into the capsular sac, pushing the capsule out to the equator. The OVD goes out into the equator, and now we can put in our capsule retractors in that location. So where there's no zonule, I typically want to put in a retractor every 45 degrees. And there comes our third location for a capsule retractor. And I'm inserting this retractor. This is essentially the central one. You can see the capsule wants to move a little as I go over it there. And here I'm noticing that the capsule is kind of moving into the periphery. I can't quite see the edge of it there. And there goes our second retractor. Same situation, the edge of the capsule disappears. And that's a bit unusual. Here goes our third one. And now I'm wondering if we may not have a rent in the equatorial capsule. I'm going to sweep here looking for vitreous strands. Nope, don't see anything. And that might be one right there. Yeah, I think it probably is one. I'm going to push it off to the side here a little bit. Yep, yeah, I think that's a vitreous strand. So I'm going back in with the phaco tip to remove the nucleus. And let's see if the capsule remains away from the phaco tip. Seems to be so far. Take this segment. I'm withdrawing it to near the incision before I aspirate them. I've got a good amount of epinucleus here, so let me see if I can tease that out from the capsular fornix and hopefully just aspirate it. You gotta watch the posterior capsule, you know, watch for infusion misdirection syndrome, because, you know, fluid can go right through that zonular dehiscent area as easy as can be. I don't think it'd be possible to continue on here without the capsule retractors, though. And there's that strand of vitreous. I'm not really tugging on it because it won't occlude the port, but I've seen it a couple of times. You could see it shiny there. Alright, so we've got the epinucleus pretty well mobilized and aspiratable. And I think we'll wind up using the vitrectomy tip here in a minute to make sure we get that strand out of the way. And let's do a little INA away from that vitreous strand. I still don't see that capsular edge in the nasal quadrant. And some infusion misdirection syndrome there. Really don't have a lot of space between the anterior and posterior capsules. So I'm going to use this spatula and essentially use it to try to protect the posterior capsule when necessary, when it gets up near the port, and try to strip out little bits of this cortex in different directions. Now the capsule is not resisting terribly well. The only resistance is from the capsule retractors nasally. And there's that vitreous strand getting in our way, and we're going to have to amputate that. I'm going to make a puncture here and put a chamber maintainer in here. I'm going to put the chamber maintainer into the side port incision. I'm going to now put in the vitrectomy tip, and let's amputate that little strand. And there we go. And now let's proceed back to INA and see if we can get out the rest of this cortex. I'm going to keep the port up. Don't see any more vitreous anywhere. So it may well be that the posterior capsule, the equatorial capsule, is intact, but I'm still suspicious. No way to remove this cortex except deliberately, slowly tease it out and try and tangentially pull on it so we don't exert force on the zonule. Could put in more capsule retractors. It's a real option now, but I'm still watching to see if I think we have to do that. I'm back in with the vitrectomy tip. I'm going to take out this little area, piece of epinucleus. And now I've turned off the cutter, and I'm going to use the cutter as an aspiration device. And I'm going to make a puncture over here because I want to have access to this cortex. Again, the cutter is off. The INA tip was difficult to get into that position, or would have been, and especially with infusion misdirection. If I couldn't get this cortex out this way, I'd have to either do an OVD injection, hope the capsule stayed back, pars plana vitrectomy, and remove vit, but I'm going the slow, deliberate route, at least for now. A little tricky to get this cortex, but making some headway. Trying to get the port right against it before I step on the pedal. Tease it out. And there I got a good chunk of it. And go back over here and see if we can get this. And I just cut that off. Okay, so we don't have much cortex left here. I'm going over here with the vitrectomy tip and just taking that last piece of cortex. Again, I don't seem to have a capsular opening. Sweeping again, putting in some OVD. So I've decided, let's try and put in a sulcus IOL and capture it through this very nice capsular excess. I'm loosening the 3 capsule retractors. And I'm going to remove them. A little more OVD, filling out the capsular sac. I'm going to grab this with forceps. You could go to a capsular tension ring and put an IOL in the capsular sac, I'm just not 100% sure that the entire capsule is intact. So I'm going to go sulcus capture. So here comes the last of the retractors. Making the incision just a tad larger for the 3-piece IOL that I'm going to inject. Putting some OVD into the sulcus to expand the space. I'm going to insert that 3-piece acrylic intraocular lens, directing the leading haptic right into the sulcus. I can see the dehiscence of the nasal zonule. And I'm just going to take the spatula now and flatten the optic. And use a Kugelin hook now. I'm going to dial the trailing haptic into the sulcus before capturing it. And capturing is obviously going to be extremely important here, because we're not going to want to rely on this zonule to keep the IOL centered. I think if we just put it in the sulcus and left it, it would almost certainly dislocate. Decenter, to be sure. There's a piece of lens material that will either visco express or get to flow out of the eye here in a second. And the IOL is pretty well centered, and I think I could capture it now. Let's see if we can just depress that optic into the bag, and as I did that, that lens material flowed out of the incision. So let's just now double check and put this spatula underneath. I'm going to sweep. There's the capsule there. It's behind the optic. So I'm going to depress the optic into the capsular fornix there. And now I'm going to do the same or similar thing on the temporal side of the optic. This haptic, however, I can see is not fully into the sulcus. I got to dial it again. There we go. Okay, now it's captured on both sides there. Verify this by depressing there, and yep, good. Okay, so there's our captured optic. I don't see any vitreous anywhere, no strands. I'm going to irrigate the angle and get out OVD and a little bit of lens cortex floating around there. I'm going to put in some myostat now. So now I'm going to put in the 2 eye stents. Here's the first one injected, and moving over here more inferior, the second one is now injected, and there's a little blood reflux coming there. And now, since I'm not using a toric IOL, I'm making penetrating limbal relaxing incisions at that axis. I'm going to wiggle the keratome. And that'll take care of about a diopter of cylinder. So here's our final view of this rather complex case with an absent nasal zonule, sulcus PCL, optic capture, and 2 eye stents injected into the nasal trabecular meshwork.